Wait, you're in my lane?
No, not at all.
Are you not paying attention? Are you texting?
I was just checking in with my mom. I was telling her that I thought we'd be home by 6.
It's okay. There's enough time. Just pay attention.
I'm not even halfway through my text. There's no way. I'm not even going to look up.
My babies are in the car. You have to pay attention.
It's just supposed to be a quick text. I'm so sorry.
Good evening. I'm Dr. Tami Prince, and you are watching Health Tips with the Nation's Bedside Doctor on Clark TV Network, where we believe in the future. On this show, we have real talk on real issues that affects our communities every single day. Happy Thursday! Oh my God, we finally made it!
Finally made
it! Oh my God! Hopefully you had a productive week. I know I did. If you did, you need this weekend to recharge. And so you're ready to take on the world next week. If you didn't quite get to where you needed to, that's okay, no worries. Find out what your next game plan is this weekend and get back on task. You could have been anywhere else on a Thursday night, but you're here with me unwinding, and I say thank you so much. I know I need to unwind, so I'm glad to be here with you, and I'm glad to have my guest today with me, Dr. Juanita Wyatt Hathaway. I'm going to introduce her formally later on in the show, but she has graced us with her presence tonight, so we're in for a little treat.
Glad to be here.
Oh my gosh, so much has happened since we were last together. It's now springtime.
First day. Yes.
Yes. Oh my God, in Atlanta we have been struggling with this up and down weather, so we finally got some great weather going on this week. So I'm just looking forward to being able to get out and just do what I like to do on the weekends, which is enjoy family and just kind of walk around and be able to get some stuff done that I can't get done in the week or when it's raining. So now you know how I like to do things. I like to highlight trailblazers in the medical field that are the reason that myself and Dr. Wyatt Hathaway are sitting before you all today. And today is no exception. It's still Women's Month, so I am highlighting another woman, and her name is Dr. Myra Adele Logan. So Dr. Myra Adele Logan was born in Tuskegee, Alabama in 1908. She matriculated right here in Atlanta at Atlanta University, which is now called Clark Atlanta University, and graduated valedictorian of her class. She went on to attend Columbia University, where she got her MS degree in psychology. She worked for the YWCA in Connecticut before opting to go on to a career in medicine. Dr. Logan was the first person to receive the Walter Gray Crump Scholarship for Young Women. This scholarship was actually put in place by Dr. Crump in order to have more black women enter medical school. So that was actually groundbreaking back in this time. And the scholarship was actually for a 4-year, $10,000 scholarship, and allowed Dr. Logan to attend New York Medical College. Dr. Logan graduated in 1933, and then she went on to complete her residency and internship at Harlem Hospital in New York. Now, while she was an intern, she met the love of her life. She met Charles Austin, who was actually a painter. He was working on a mural at the hospital, and they met, they got married, and Dr. Logan actually served as a model for her husband's modern medicine. She was actually a nurse holding a baby at the time, so once again, pretty groundbreaking. Dr. Logan became associate surgeon at Harlem Hospital, where she spent the majority of her medical career. She was also a visiting surgeon and maintained a private practice. In 1943, she became the first woman to perform open heart surgery, and that was that kind of surgery was the 9th of its kind, but she was the first woman to do it. She also developed her specialty in children's heart surgery. She worked to develop antibiotics, including the first tetracycline, chlorotetracycline. In 1951, Dr. Logan was elected Fellow of the American College of Surgeons and was the first African American woman to do so. In the 1960s, she researched the early detection and treatment of breast cancer. She also developed X-ray processes that could more accurately detect differences in tissue density, allowing tumors to be discovered earlier. Her research on antibiotics was published in a number of medical journals, such as the Archives of Surgery and the Journal of American Medical Surgery. Dr. Logan was a founding partner and treasurer of the Upper Manhattan Medical Group of the Health Insurance Plan, one of the first group practices in the United States. So it was a model for the practices that we see today, practices like Dr. Juanita Wyatt Hathaway is associated with. So that was probably the foundation for
foundation.
that.
There you have it.
Now, she also worked in several organizations, including the NAACP's Health Committee, the New York State Fair Employment Practices Committee, the National Cancer Committee, and Planned Parenthood. Dr. Logan was a member of the New York State Commission on Discrimination during Governor Thomas E. Dewey's administration. In 1944, however, she, along with 7 other members, resigned from this commission after the governor shelved anti-discrimination legislation that they had drafted. So she was kind of a trailblazer. In that regards, too, outside of the operating suites and medical fields. So I applaud her for that. Dr. Logan was an accomplished classic pianist.
Wow.
Yes, so she retired in 1970, and then she went on to later serve the New York State Workmen's Compensation Board. Dr. Logan died of lung cancer in 1977. So Dr. Logan is the reason that we're here. So I applaud you, Dr. Logan. Thank you so much.
Yes, thank you.
Now, more medical news. Here's your 5-minute consult. So, a lot of patients talk about how their libido or their sex drive is low. And of course, Dr. Wyatt Hathaway and I deal with females, but also men have this issue as well. So there was a study that came out. Actually, there have been several studies, low-powered studies, meaning that they don't have, a lot of patients that are in these studies, but it's enough where they can kind of see what a trend is going to be. And what they did was they found that the trend supports the idea that exercise can boost libido and sexual health in both men and women. So, several studies were done. One of them actually looked at how often exercise should be done. And what was actually found, and this was kind of intriguing to me, is one-time acute exercise sessions seem to boost sexual arousal via activation of the sympathetic nervous system. So we know that's the fight or flight. Response, but it's unclear whether these findings actually hold true if you're doing exercise on a chronic basis. And notably, chronic training yields lower overall sympathetic autonomic neural tone and lower sex drive. So
Moderation.
Moderation. They're trying to pinpoint exactly how long exercise should be done. And, right now we can't tell you, you need to exercise 2 hours, 3 hours, 5 days a week. But we do know that some exercise is needed. So let me give you some pointers on possible exercises to help you out in the bedroom. So strength training is actually the best one. And you would think cardio workout would be better because it's pumping the heart, but actually strength training, the use of resistance and weights is actually boosting libido more than the cardio workouts, or like when you're on your treadmill or you're running and things like that. That's what we consider the cardio exercises. We think that is because strength training tends to relieve stress more.
Right.
And if you think about it, it actually makes perfect sense. When you have had a hard day at work or wherever, and you start lifting weights, you get that euphoric sense.
Exactly right.
And it calms you down and mellows you out, and so that way your stress is at a minimum after you do those exercises. Kind of like you're getting your aggression out, you're taking it all out on that weight, as opposed to somebody else.
Exactly.
So that is an important finding. Kegels.
I was going to say core must be in there.
Yeah. So, normally we think of Kegels as only a women's exercise, where women are using their pelvic muscles to strengthen them so that they don't lose bowel or bladder function. But we also know that men can also benefit from doing Kegels. And when women do it, they can maybe have a more powerful orgasm.
Mm-hmm.
And when men do it, they can actually help decrease or delay
Premature ejaculation.
So squeeze. squeeze. If you need to find out how to do Kegel exercises properly, make sure that you talk to your doctor about that. They will give you some good schematics on how to do that. Another one, yoga. A lot of people do yoga. I love to do yoga as well. Do you do yoga?
I've done yoga sparingly.
So it's not for everybody,
It's
but
not for everybody.
I like to do it. And researchers actually found that yoga helped with premature ejaculation, surprisingly enough. So yeah, and in women, it actually improved all domains of sexual function, including desire, arousal, orgasm, satisfaction, lubrication, and pain. Because we deal a lot, I know, with women that sometimes will have pain during intercourse. So get your yoga on. They found that yoga is actually more beneficial in women that are older than 45 than the younger women. Why that is, we don't know yet. They're still doing research to find out some more information on that. But that was an important finding that definitely needs to be looked at some more. Walking. So everybody always thinks, oh, you need to, run. Well, actually walking and swimming have found to have some benefit with your libido. So just 30 minutes of walking a day may decrease the risk of erectile dysfunction in men up to 41%. So that's a lot. And Harvard actually did that study. In a separate trial, it indicated moderate exercise may also help prevent erectile dysfunction in middle-aged obese men. Swimming also, just like the walking, for 30 minutes 3 times a week may boost sex drive, once again according to the Harvard study. And it can also help with weight loss, which then in turn can improve sexual endurance. So, once again, make sure that you see your doctor before you start any kind of exercise workout. We want to make sure that things are being tailored to you.
Right.
Because I can't do the same workout that Dr. Wyatt Hathaway does, and she can't do the same workout as somebody else. So it's got to be tailored to you. And, the whole point of this study was really to further assess how exercise really does a body good.
Absolutely.
And so, just start walking, start swimming.
Just get off the
Do
couch.
something, get off of the couch.
Right.
So that is your 5-minute consult. Hopefully you are now in the know with the latest and greatest in medical news. When we come back, I'm going to formally introduce my guest, Dr. Juanita Wyatt Hathaway, and we're going to get into an important topic, endometriosis. Stay tuned.
Awkward. Do I look familiar? I should. You might remember me from here. Here. Or maybe even here.
But an awkward silence can be a great thing.
It can actually be a perfect moment to reach out to a friend and ask if they're okay if they seem down.
It doesn't matter how you say it.
You alright?
Everything's okay?
All G?
You alright, girl?
Oh, you cool?
You bugging dog.
Just show you're there for them.
Go on, Kelly. Seize the awkward.
Hey, you haven't really been yourself lately. Are you okay?
Find out how you can help a friend with their mental health at seizetheawkward.org. Good.
I don't remember how it started.
Go to that.
We just found it. Our back and forth. Victory. Fumble. Repeat. It always came back.
Dad!
You made time.
That was perfect. Okay, here we go, throw it.
Yeah.
You probably don't remember what you told me.
Nice.
But I heard every word.
We are back from our break and we are here to discuss endometriosis. You know, March is a month of minis and endometriosis awareness month is in March. I'm actually wearing yellow to represent endometriosis, and even though I'm an OBGYN and I can talk about this ad nauseum, I thought I'd bring some backup here. So I have got my guest, Dr. Juanita Wyatt Hathaway with Atlanta Women's Specialists, here to dissect this topic for us. Before I have Dr. Wyatt Hathaway jump in here, I'm going to actually read her bio. So Dr. Wyatt Hathaway did her undergrad training at University of Illinois and her medical school at Boston University. She completed her residency at New England Medical Center Tufts University, so she kind of stayed up north like I did for her education, then brought those good skills back down here to Atlanta, where she is affiliated with Northside Hospital.
Yeah.
She is board certified with the American College of Obstetrics and Gynecologists and has been in practice since 1994. Dr. Hathaway is a partner with Atlanta Women's Specialists. She enjoys reading, traveling, and cooking. She knew from an early age that she wanted to be a doctor. As a physician at Atlanta Women's Specialists, she gets to help women in their health care needs every day. For Dr. Hathaway, one of her most exhilarating times is witnessing the moment when a mom looks at her new baby for the first time. That is the best
That is
experience
priceless.
ever. That is priceless. She also enjoys being able to take care of her patients over many years, helping to resolve problems and watching their families grow and change. Establishing a rapport with her patients is extremely important to Dr. Hathaway. It allows her to better help her patients. She believes laughter is a large factor in overall health. Humor is a part of her personable manner, which she uses to help patients feel more comfortable, and I can vouch for that because she makes
you.
me feel so comfortable. She's actually my personal physician, so I handpicked her, so she's good. Dr. Hathaway is quoted as saying, "I always want to find out what's troubling a patient or what her expectations are. I listen in order to understand her needs so that we can work together to accomplish her goals." Dr. Hathaway encourages her patients to educate themselves about their medical situations and offers guidance on finding the most accurate and beneficial research available. Welcome, Dr.
Well, thank you for
Hathaway.
having me. I'm so happy to be here.
Yeah, so she just got back in the country from a beautiful trip to Argentina.
Argentina.
Oh my
yes,
gosh.
it was wonderful.
I know it was.
And I was able to spend some time with my family, my 2 kids, who are one's 24, one's 21, and so it was great to see, something out of the Americas, and look at them through their eyes as they explored other places. So it was a lot of fun.
I love to go to other countries and see how they practice medicine
Yes.
because it's completely different.
It is.
You know, we always think, oh, the American way is the best way, but there are more than one way to skin a cat, and so. I've gone to 5 of 7 continents and was able to see how everyone practices differently. So, that's a wonderful experience
That
to be able to
is.
get out of the country.
And you learn so much with that and can bring it back to your own practice.
Absolutely,
as well.
absolutely. And it makes us more well-rounded.
Exactly.
Exactly. So thank you for coming back. I know you're tired from that.
Oh, it's fine. It's fine. The nice thing about Argentina is that there wasn't a really big time change. They were only a couple of hours ahead of us.
Oh, that's good.
And then when we jumped ahead, we actually were only an hour behind them. So
that's
it
good.
wasn't that jet lag that you get when you go to Europe. So it's not bad.
That's not bad, yeah. So I was, for some reason, imagining that they were about 6 hours ahead.
No, I thought so too, but I was pleasantly surprised.
Oh, that's awesome. That's awesome. That's even better. So I'm going to give you some statistics on endometriosis. Both Dr. Wyatt Hathaway and I have treated a multitude of patients with this common issue. So approximately 11%, that equates to about 6.5 million American women between the ages of 15 and 44 are actually afflicted with this. More commonly, we see these in women who are in their 30s or 40s, but once again, it can happen
At any age.
Right. So, just because you're not 30 or 40 doesn't mean that you don't have it. Just because you're, 15 doesn't mean that you don't have it.
Right. That's exactly right.
So.
And they actually can see it sometimes in menopausal women as well, when you really shouldn't have activity, but.
Exactly. We'll talk about that a little bit later, because we were always, taught, once you hit menopause, you shouldn't have any symptoms, but that's not actually true. So we'll tell you why that's not true. Right. Now, what is endometriosis?
So let's start with what is the endometrium. So the uterine lining is called the endometrium, and that's what we typically see every month with normal menstrual cycles, and that's what you're sloughing and passing as a period. And endometriosis is actually that layer of tissue that's lining the uterine lining cavity that actually sheds in a retrograde fashion, so going not out, but
back
going
up.
backwards, exactly. And so that's one of the theories about where endometriosis originates. There are a couple of theories about endometriosis and how the etiology or the beginnings of endometriosis actually occurs, but that's probably the most common theory, which is that retrograde flow that's going from the uterus through the fallopian tubes, and then it's, finds itself implanted on different aspects or surfaces of in the abdominal cavity. The most common thing that we see is that the endometriosis and the implants actually occur on the ovaries. and in the areas that surround the ovaries. So like the fallopian tubes, the surface of the uterus, both the front part of the uterus and the back part of the uterus.
The tissue surrounding
Surrounding it. But sometimes we can actually see endometriosis implants on things like your intestines. They've seen it as far as within lung tissue. So it's very interesting. There's a lot that we don't really know about endometriosis as well as far as really who's going to get it. And all the theories behind how it does spread, or why do we see it in remote places like lung tissue?
Yeah.
Some theories basically say that it might be some travel within the lymphatic system, within the bloodstream, that can carry it to more remote places. Probably the most common theory, as I said, is the retrograde flow, which makes most sense for that localized implantations that we may see.
Correct. And I think the lymphatic probably makes more sense for the remote
distal.
areas that we can see it in. Right. I've not actually seen it in the lung. I know that it happens. Have you ever seen that?
I've never seen it in my career, no, but definitely, have heard.
We read about it.
Exactly. I've seen it. Probably the most remote place I've seen it was in the upper abdomen, kind of near the liver, but kind of more on the peritoneal surface, the lining of the abdomen. But, yes, I mean, it's fascinating that you have people who have endometriosis that can cause things like the lungs to collapse. And that's oftentimes how they diagnose it. So, or it looks like other disease processes. You can have like little nodules that they see on CT scans when they're looking at the lung, and they may think that it's something else. They may think that it's like a malignancy or some sort of, other lung disease, and then the biopsies come back and that's what it is.
So who's at risk?
Well, as you indicated, we can certainly see it in the reproductive age woman. We can see it in the adolescents or the pre-menarchal women, girls, and we can also see it on the backside in those women who the ovaries have stopped working and they're no longer menstruating, but they can still have some residual effects from endometriosis that they might have had during their reproductive life. But who's at risk? One of the theories, again, that kind of comes up is maybe some women who might have some sort of immune deficiency. They may be more at risk of having inflammatory changes occur, and as a result, endometriosis. Any woman who's in their reproductive age where their ovaries are working, certainly can be at risk for having endometriosis. We can see it in populations that are having difficulty with conceiving, so the infertility population may also find that they have endometriosis occurring. However, it's only, of all the people who have infertility, it's about 15% that will have endometriosis. So certainly it may be associated, but it's not necessarily always the cause of infertility. But that population may be at risk of having endometriosis diagnosed more often.
And also we can see it in families. So
Yes.
I've seen it where like a mother had it, an aunt had it, a sister had it,
Right.
and then now the patient also has it herself.
Right, and there have been some genes that they have actually been able to map out and find that some families that have particular genes might be at risk of having it trend in their family. But endometriosis is not cancerous. We'll step back to that a little bit later. But some people who have those genes, those gene lines might be more in a carcinogenic type, pre-cancer type of mutations. So, but in general, we think of endometriosis as a benign process, non-cancer.
Correct. We can also see it in women that don't have children.
Yes.
as you said.
Right.
And
so those who've had cycles that started really early in life, the basic exposure to estrogen is the key thing that's going to probably place women at risk. So as you said, women who've not had children, they have many more cycles where that estrogen is continuously being produced. They don't have that interruption of a 9-month pregnancy, and that estrogen is just flowing constantly.
And you may not think that 9 months is a long time, but it's long enough where it gives the body a break.
Exactly. And for the benefits of breastfeeding also can help women as well who have endometriosis. It, again, suppresses the ovaries from producing estrogen. So by suppressing the ovaries and that production of estrogen, that helps reduce the risk of a woman having endometriosis, or maybe even if you have endometriosis, suppressing your symptoms. And women who find themselves having cycles later in life. The average age for menopause is about 51, but we certainly see that there are some women who are in their mid-50s still having cycles, and so it's that, again, prolonged estrogen exposure that we see.
Also, women that have longer bleed times.
Yes.
Longer than 7. Most cycles last between 5 to 7 days. So a woman who falls outside of that 7 days,
Right.
It's more at risk than somebody that has less than a 5-day
Exactly.
period. Once again, like Dr. White Hathaway says, because of the longer exposure to estrogen.
Right. And then the other category where we often see it, probably not as often because you really don't have women with this diagnosis that often, but in those who have some sort of obstruction in their reproductive system. So if there is some reason why their uterus is obstructed and that flow is not going out, and then again, that retrograde backflow, so to speak, is probably going to be the reason why they will have endometriosis.
A lot of times, we see that in women that have what we call a congenital
anomaly,
or issues that with their reproductive system that happened during the process of the fetus forming properly. So we can see that in those kind of women.
Absolutely.
Rarely, I guess, if the polyp is big enough, maybe you can see it
where it's
obstructing the lining
or fibroids.
If it's pushing in on that lining, it can cause it.
Right.
So those may be other reasons why the blood can't get out, and then it stays and goes out where it shouldn't go out.
I'll tell you one interesting thing. When I was a resident, actually, some cultures have that female circumcision.
Yes.
And so the worst case of endometriosis that I remember as a resident was a young lady who came from that culture. And so she was basically obstructed, but not, it wasn't a birth defect. It was,
it was scarring.
It was
from
scarring
that. So
from that.
what female circumcision is basically they take the outer lips and the inner lips on the severe side.
Right.
And once that happens, then scar tissue forms around that area, and they're left with a little small pinhole. And supposedly that pinhole is large enough for the menstrual cycle to get through, but that's not always the case.
Absolutely.
And so I can imagine that she had tremendous amount of issues as a result of that.
Right. And of course, along with the pain that she ended up having from the endometriosis. So, yeah.
Absolutely. Now, we touched on some of the causes of the endometriosis. Surgery is a cause as well, because I've seen it where a patient actually had endometriosis within the scar tissue that was created by the surgery.
Right. Sometimes that if they have endometriosis, and sometimes there can be small implants that you don't even recognize, but enough that once, especially in laparoscopy, you're kind of bringing the instruments through the belly button. I've seen it in the umbilicus.
Yes,
exactly.
I have too.
And then those small little cells are just brought through up through the umbilicus as the instrument's being brought out, and they just implant right there, and there you have another source or another place where they'll may experience pain and things like that if they have symptoms of pain with endometriosis. Not everyone will have pain, even though they may have endometriosis.
Let's talk about some of those symptoms.
Yeah.
Obviously, pain is the most common symptom.
Right.
And it can be usually pain in the pelvic region, but pain can be pretty much everywhere.
Right. So, as you said, most times I think women who have endometriosis and have pain with endometriosis, they may have what we call dysmenorrhea or painful periods. The majority will have pain during their cycle, and oftentimes the pain can resolve after the cycle is over, but some will actually describe pain that kind of comes prior to their period starting. And then you have some people who have more chronic, long-lasting pelvic pain that can be attributed to endometriosis. And those are kind of the harder people, I think, to manage.
And usually that, what I've seen is when they have that kind of chronic pain that just persists and it doesn't really come and go with the periods, it's because there's implants in other areas. Like the intestines.
Correct.
Because they can have pain when they're having bowel movements or when they're urinating because there are implants on the bladder and on the bowel.
That's right. And they have those symptoms that can be mimicked or can mimic other things. So sometimes if you have bladder implants, you may have urinary frequency, you may have kind of urgency, need to go to the bathroom all the time and urgently. And we may think it's, a common urinary tract infection, and you get kind of gone down that road to work up that, and then everything's negative, and then you don't really know exactly what's causing it. And it can certainly be endometriosis involving the bladder. The same thing on the GI side. You can have, some women have chronic constipation. As you said, they may have pain with defecation when having bowel movements. Sometimes they can have nausea and vomiting associated with that as well.
Bloating.
So bloating.
So all of the GI issues that you can think of, it can happen as a result of that. And as Dr. White Hathaway alluded, not every woman has pain with endometriosis.
Right.
So we don't want to box every woman who is the diagnosis with having pain, because you may be one of those lucky women that don't have it at all.
Right.
But you have other things that lead us to believe that you may have that. Infertility is a big one.
Right, exactly. And sometimes we actually find endometriosis as an incidental finding.
Like we're going in looking for something else.
For something completely different. You may have someone who is going to get their appendix taken out, and then, I've had general surgeons say, oh, by the way, I've taken some pictures to show you what I found at the time of taking her appendix out, and, splattered with endometriosis. Never had a symptom, really no pain. That's the other odd thing about this whole process, is that you can have some women who have a significant amount of endometriosis when you physically look at the inflammation that has occurred in the pelvis at the time of surgery. And some of them have absolutely no symptoms.
Nothing.
And then you can have some that may have a little bit of endometriosis, and they can be debilitated by this monthly pain that they experience. So it's a very odd disease, certainly, I've found in my practice.
I agree. And, I've had patients that come to me and they say, Dr. Prince, you're like the third physician that I've seen, and the first one to actually diagnose me with endometriosis. Why is that? You know, it is very undertreated, and a lot of times, you know, we used to be under the impression that if you went in for a laparoscopy and you didn't see anything, then that meant that they didn't have the disease. But that doesn't necessarily mean that. They could have something so small that it's invisible to the naked eye.
Correct.
And in that instance, I still will treat based upon my suspicions. You know, when we are evaluating the whole patient, you don't just take one piece of the evaluation. You have to put the entire picture together. And if just because lab work or surgery doesn't tell me something, but I still have that sneaky suspicion, I'm going to treat, and I have not been wrong yet. Once I treat, the symptoms get better just like that. I'm like, yep, that was the right diagnosis.
And if the symptoms don't get better, you know, it's the treatment is reversible. The things that happen with treatment, you know, it can stop and go back to, you know, what you were pre-treatment. So there is certainly no. You may gain some insight, and you don't really lose a lot by treatment.
Now, are there any other health issues that you're aware of that are linked to endometriosis?
So, you know, again, we kind of talked about that small population of infertility that might have issues with endometriosis and lead to some of the reasons why they might have infertility problems. Mostly, we find that that's, again, endometriosis can cause a lot of inflammation. That's typically the people who have pelvic pain and things like that. There is inflammatory changes that have occurred that causes tissue that typically is kind of free of each other and very independent of each other. It's almost like a glue gun has been shot off in the pelvis in some people who have significant adhesions and inflammation. And there's like webs of tissue just that kind of gathers everything together. But, you know, that inflammation causes a lot of pain. So it can certainly distort the way the pelvis looks when you look at it. Again, going back to why some people might have infertility. We did talk about endometriosis being a benign process, but there is very small set of people who might have risks of having ovarian cancer associated with endometriosis. When you have ovarian cysts or what we call chocolate cysts, where the endometriosis causes inflammatory changes, and it also causes the ovary to kind of bleed, and then that blood gets trapped, and then more inflammation occurs, and then that capsule gets thicker and denser around the ovary, and you end up having a lot of blood accumulate in these cysts that form on the ovary. And when you open them up, they come out and it looks like chocolate.
Just like chocolate.
Yes. It's all based upon red blood cells that's kind of been sitting there over time. But sometimes we can see that some women, very small a group of women, but they can have malignancies that's associated with their ovaries.
And primarily, I think it's because of the body's way of trying to repair itself. So how cancers normally happen is something incidental, like the body is repairing itself because there is inflammation. And if it's happening repetitively, at some point in time, the body gets tired and they start to not be able to repair itself in the manner that it does. And that's how you get these mutations in the genes that can cause the cancers.
Right. So, and that is one of the things that we see as far as endometriosis leading to other things. We've actually, I don't think it's talked about that much, but sometimes we've seen that preterm labor can be associated with women who have endometriosis. Certainly not the major cause of of preterm labor, but we have seen that incidental findings that sometimes that can be a factor as well.
Once again, it's probably because of the inflammation
Exactly.
That's occurring. Just because you're pregnant doesn't mean that endometriosis is not there. It's still present.
Right.
And it can be inflamed and causing those issues because infection, we do know, is one of the biggest reasons for preterm labor.
Exactly.
So, the inflammation can also become infected.
Exactly.
And that can lead to the preterm labor. But some autoimmune issues,
Yes.
like lupus and hypothyroidism and multiple sclerosis, we can also see endometriosis occurring in those two. Once again, the inflammation.
The inflammation
process.
is the background.
It's the background.
Right.
Chronic fatigue syndrome.
Right.
And also some
And-
allergies.
Yeah, and I think also as probably a result of the chronic effects of having that kind of inflammation and pain. I mean, emotionally, depression. I can certainly see that.
And I think that's overlooked
I
in
do
a lot
think-
of
I do
women
too.
because in any kind of illness, I can't fault somebody who has to live with this every
Absolutely.
single day to not have feelings like, why is this happening to
Right.
me, and get down.
Exactly. And then especially as it impacts the rest of your life, your, physical relationships with your spouse or your partners, and not, again, decreased libido and pain associated with intercourse. I mean, all those things can emotionally impact us because we are not our best selves.
Absolutely, absolutely. And I had one case where it did affect the relationship with the husband. I had them go to counseling so that he could also understand what it was. It wasn't that she did not desire him anymore.
Right.
It was just painful
Exactly.
for her to be intimate in that regards. And so counseling definitely did help. So, if you are suffering from endometriosis and you are also having relationship issues, don't hesitate to talk to your physician and don't hesitate to ask for help.
Absolutely.
Don't think that you're weak because you need to be treated for depression or anxiety. It's common to have that in this condition.
Absolutely.
So I'm glad that you brought that up because that is a big issue that we see. Now, how we kind of talked about some of the ways that we diagnosed endometriosis, but let's take them step by step.
Sure. So, again, probably the first thing that's going to happen is that you have a patient come into the office, and it may take them some time before they actually elaborate on really what their problem is.
And they may not even know
what it is.
So, so we talk about, the patient is a poor historian, but they may be a poor historian because they don't understand what's happening with them.
Exactly. So it's important to kind of get a good, thorough history and talk about things like sexual function, like, simple things as far as like bladder and bowel habits and things like that. And take the time to kind of listen to the patient and try to get those things out of them. But again, pelvic pain or discomfort sometimes is going to be the major thing that people will describe. And then typically doing an ultrasound to kind of evaluate the pelvis, look at the ovaries, look at the uterus. You can sometimes on ultrasound have those cysts that we talked about, that they have very, very strong characteristics when we see them, and we can increase our suspicion of endometriosis occurring based upon what we see by ultrasound and how these ovaries look on ultrasound. Sometimes you can have absolutely normal ultrasounds. That doesn't necessarily mean that you don't have endometriosis. It just means that you have to kind of work a little bit harder to diagnose it.
And you may even do more imaging. I've not actually had to do an MRI on a patient, but I know that some patients have come in having an MRI done.
Right. And then, doing a pelvic exam, you kind of, sometimes you can even feel the endometrial implants, depending, on where they're deposited. And if they have, and we can get into this in a little bit, depending on the stage of endometriosis, you actually might be able to actually feel the nodularity, the grittiness.
It's supposed to be smooth.
It's supposed to be nice and smooth. The area between the vagina and the rectum, or underneath the bladder. But sometimes you can have this kind of grainy, very hard nodules, pebbles that you feel in that septum, in that space, and that's a very good suspicion for endometriosis. And then again, we talked about actually doing a laparoscopy to be able to visualize changes that can occur from endometriosis, that inflammation causing, again, that web-like gathering of tissue, what we call adhesions or scar tissue, that we can sometimes see that is a reflection of endometriosis and the inflammation that occurs with that. We can also see things that might be much milder changes, where you might just see little speckles on the lining of the pelvis that could be kind of red. The hallmark of endometriosis is almost like a gunshot splatter, where it's kind of a brownish, dark black little implant that you can see on the ovary, on the tubes, again on the layers of the surface of the uterus. Those are kind of probably our classic things that we see. But as you said, sometimes to the naked eye, you can't really see endometriosis. It may be there. Oftentimes people, you might want to do biopsies in areas that you suspect that you have endometriosis, but it's not recommended that you just do blind
random
biopsies,
right,
if you don't see it. So in certain circumstances, then you have to go with your gut, and you have to decide whether or not you clinically suspect, based upon her history, based upon some of the symptoms that she's eliciting, could she have endometriosis. And then sometimes by treating them, give them a trial of treatment, if they respond, then that's probably what it was, even though you didn't see it. If they didn't respond, then you again have to start thinking about other differential
options,
diagnosis. And some people don't necessarily go to the surgical route. They will, if based upon their clinical suspicion, talk with the patient and say whether or not treatment might be something just to try and see what happens even before you go into the surgical.
Yeah, normally you'll do like a trial of 6 months to a year,
Right.
And then you may want to opt at that time to go in and look at things and see if there is any difference.
Right.
At that time. And it saves a lot of times patients are, who wants to have a surgery?
Right.
So they're always, fighting like, do I have to have a surgery? Well, actually, no. We can try the medical route first, and then we can go back at a later date if we need to do that.
Right. And there's, sometimes simple things, just like using oral contraceptives can be your first line of treatment, and can, by decreasing the amount of bleeding that one has with using the pill, or some sort of combined oral contraceptive, or even the progesterone-only type medications. By decreasing that lining, you have less blood flow. You might decrease the painful period aspect of endometriosis, or what we call dysmenorrhea, and that can help people who might have minimal symptoms. So you may have people who have more milder symptoms. When we stage endometriosis, we talk about minimal, mild, moderate, and severe, based upon how much impact this inflammatory process has caused in the pelvis, or if there is distant endometriosis noted in other areas along the intestines, or if it's really deep implants that are deeply seated into the tissue, then that kind of increases the severity of the disease. So again, you have conservative management that you can do. When you have women who have endometriomas, where you have the large cysts on the ovaries, depending on how large they are, you might decide to, again, be conservative and observe them if they're not having a lot of symptoms. But symptomatology, if they're having a lot of pelvic pain, pelvic pressure, or if by ultrasound these masses on the ovaries are concerning to you, you're not sure, is this something that is endometriosis, or am I missing something else? Then, the surgical management is what we're looking at.
Absolutely.
Yeah.
Now, you alluded to it. There are different stages of endometriosis. There are 4 of them.
Correct.
Let's go through what the stages are.
Sure. So again, there are 4 stages. What we call minimal is when you have just small superficial endometrial implants, and we only make these stage assessments based upon surgical evaluation.
Correct. Like you can't
can't
do
just
this,
guess it.
Just okay.
Right.
Yep, I think she's got a 3rd stage.
right.
Like, yeah, no, I don't have X-ray eyes. I can't see that.
Right. And you're not going to see it on an ultrasound or an X-ray, but surgically, when you have that laparoscopy or whatever surgical intervention that you have, when you see it on the pelvis, if you see it just kind of scattered spots on the ovaries, it's not really deeply implanted into the ovary, then that's typically a minimal classification. Mild classification is a little bit more implants scattered on other surfaces, maybe on the uterus, tubes. And then when you have other implants that are either denser, you have more inflammation associated with it, you have that scarring we talked about, that's when you kind of progress to your moderate to severe levels. The moderate may be that you have some on the ovaries, on the uterus, maybe some scattered on the bowel. When you have these large, everything's adherent and the pelvis is really just like scarred together, and then that's severe.
That's severe, and we normally call that frozen pelvis, pretty
frozen
much.
pelvis, right.
So if you ever hear that term frozen pelvis, it's because everything is stuck
Correct.
together and nothing is free. And that is the most severe. That generally takes a lot of treatment.
Right. And that's when, the birth control pill is probably not going to be the thing that's going to be effective.
No.
You're talking about surgical treatment, probably if you're starting, you're there, you're looking at it, you're going to kind of cut away some of the adhesions, and, there's laser to some of the scar tissue and the implants. And then you're going to need some post-surgical management, which again may be a long-term treatment plan that you're going to establish with your patient. There are the typical kind of more traditional things that we've grown up with are chemicals that are basically injected to kind of trick your brain to stop stimulating your ovary to produce that estrogen. Again, going back to the beginning when we talked about it's estrogen that is the cause of endometriosis and the effects of endometriosis, the stimulation and the encouragement of endometriosis. So by shutting off your brain with these medications, the most traditional thing is Lupron. It's an injectable medication. It's been around since the 1990s, I think, so somewhere around there. Because I'm doing residency, we were just starting to use it.
Yeah, I was just coming, I think, into medical school around that time when they started really doing that.
So it basically shuts off the pituitary from producing a hormone that basically triggers the ovaries to increase more estrogen production. So it puts you in a temporary, which is very important, temporary menopausal stage.
Yes, temporary. That means that if we stop it, you will start menstruating again.
Right. And so, but with that, gives you those menopausal symptoms that
Hot
some people can get
flashes
hot
and
flashes and night
vaginal
sweats,
dryness.
vaginal dryness that can also interfere with intercourse and libido because if it's dry, you don't want to necessarily do it.
That's right. That's right.
But there's things that you can do to kind of help offset that. And sometimes even mood swings and mood changes and frank depression.
Yeah.
Again, the treatment is not necessarily something that you just jump into. You want to really have a thorough discussion with your patient to kind of make sure that they understand what some of the effects may be.
Yeah, treatment has to be tailored patient, to patient.
Right.
Just because you may use, say, Lupron on one patient doesn't necessarily mean that you'll use it on your next patient.
Right.
And doesn't also necessarily mean that Lupron is going to help that patient either.
Right. That's right.
So you just kind of have to stay on your P's and Q's and just really watch the patient. Yeah. Going back to Lupron, because it does trick your brain into thinking that you no longer have to menstruate, we do like to use another medicine with that, especially if we're using that long term
Right.
to try to protect that uterus.
Right. So some of the things that we often do is more the ad bag. Is that what you're referring to? Mm-hmm. So we kind of give mostly a progesterone type medication because it's if you're cutting off your ovary or suppressing your ovary,
you don't want to give estrogen.
Right, you don't want to give estrogen because again, that's what's the culprit here. Yep. So we give the other chemical that is released from the ovary, which is progesterone when you ovulate. We give a little bit of that as an add bag. So as you're doing the Lupron injections, then we kind of give the progesterone as well. And that can kind of help stem the tide from some of those menopausal symptoms that we have discussed, and some of the other effects that it can have on bone and things like that. Sometimes we see
that uterus so you don't get possibly cancer later down the road.
Right. So so that's the add-back therapy. Usually we kind of do that if you're talking about more long-term uses of Lupron.
I usually do that for somebody that I'm going to keep on for longer than 6 months.
Right.
If I'm thinking a year, beyond that, then we need to go ahead and protect that uterus as best as we can.
Right. And as far as the Lupron, it's as we said, an injectable that we typically give. You can do it in two different ways. You can do it as a monthly injectable for that 6-month period, or however many months you're going to end up treating them. Or you can also do it as one injection that can last as long as 3 months at a time. So you may have less frequent appointments at the doctor's office.
But you got to remember to come.
Right, you have to, because once you've gone through that 3-month period, your ovaries or your body will say, okay, I'm no longer suppressed. I'm ready to rock and roll. Yeah. And they have found that even though if you feel better and you've only done one injection of the Lupron, if you don't complete the treatment, which is, again, typically 6 months at a minimum, then your symptoms will come back and maybe even worse than what they were. So it's important to keep in contact with your physician and make sure that you understand what the plan of care is and how long.
Why would it come back worse?
Well, I think because I think that that inflammation just kind of is able to kicks in and just able to breathe and so yeah.
Yeah. Now I get asked this a lot, and I'm sure you do. Is there a cure for endometriosis?
Well, I mean, there's definitive therapy you have for endometriosis, and what that means is, and that, again, you have to talk with your patient, you have to know the endpoint that they're looking for. So definitive therapy is going to be where you have a complete hysterectomy, removing the uterus, which is the lining that is the source of the implants, and taking the ovaries and tubes. The ovaries is producing the estrogen that stimulates that lining that is implanted in areas where it should not be. So you have to do all of it in order to have that definitive therapy and that cure. But Yeah, that's going to be really based upon if that person has finished their childbearing, because you are, this is a final step here. So you want to make sure that you do not want any more fertility in your future. And you will be then in a menopausal state because your ovaries, which provides estrogen that helps with that suppresses the symptoms of hot flashes and night sweats, you will now be inducing that surgically, as well as other things that kind of fall into menopause. Again, we kind of alluded to that lack of estrogen affects the vaginal walls and increases vaginal dryness. We also know that osteoporosis happens more often in menopause at an accelerated rate. We start losing that bone mass. So those are also other things that will happen once you have gone through a definitive surgery where you're taking both ovaries and the uterus. So it's a choice that you want to make sure that you're ready for, but that will.
It's not a choice for everybody.
And it's not a choice for everybody. But with time, that will be the cure.
Yep. And now I have seen it where I had a patient who actually did have definitive treatment, but still continued to have issues. And it was probably because she had implants in other places. Remember, we talked about you can have implants in the bowel, in the bladder, on the what we call omentum, which is the covering, the fat covering that goes over your organs. So you can have it in those areas. A lot of times when we're doing definitive treatment with hysterectomy, we're not necessarily removing bowel and bladder and part of the omentum, and so that's where her issue was coming from.
And although you're taking the major source of estrogen from once you remove the ovaries, there are ways in which estrogen is produced in cells, and oddly enough, our fat cells.
Another reason to exercise.
That's exactly right. That's exactly right. Our fat cells, and that's why some women who are overweight and have more fat content might be at more at risk of having things like endometrial cancer, because those fat cells actually convert into estrogen secreting tissue. And so she probably had, maybe she had some being overweight, but there's other ways that you can get a little bit of estrogen if she was taking it orally or something like that. But yeah, that's true, that can certainly be a residual effect of being obese or being overweight. So we want to, again, exercise.
Get that exercise in, and once again, just keeping the lines of communication open with your physician. Letting your physician know what your symptoms are. If you're still having them, don't be afraid, oh yeah, I had this surgery, I shouldn't be having them. Well, there may be another issue that needs to be looked into. And so you never want to keep anything from your physician.
Absolutely.
Now, is there a particular birth control that works better for endometriosis?
I think, the symptoms of endometriosis, I think some people have found that doing continuous combined contraceptive therapy has been more beneficial, mostly because you're, again, trying to reduce the number of times you're having a menstrual cycle, which decreases the pain with your cycle. I think in that respect that birth control pills can be the most effective way if your symptoms is really based upon your cycles. If you're having just that chronic, constant, regardless of if you're on your menstrual cycle or not type of pain, I don't think that they have found that it has been as effective.
I agree. Usually, and when we're talking continuous pills, that means that, in the pill pack, you have that, what we call pill-free period, where there's 7 days of there's a pill that's there, but it doesn't have any of the active hormones in it. And instead of taking that, we have you go right into another pill pack, And, patients always say, well, don't I need a period? No. As long as you are being cycled on something.
Right.
It's only an issue
when it's
there's-
spontaneous and you're not getting a period
Exactly.
because that's who you are. In those cases, then there can be some consequences
Yes.
when you don't get a period, and that can be unhealthy.
But if we're making you not have a period because we're cycling you, then it's okay.
Right. The other thing I always want to strongly, again, talk to your physician, because oftentimes you'll have someone say, oh yeah, I just kept continuing my pill. Well, not every pill is appropriate for continuous use. And you really want to make sure that your pill pack is one of those pill packs that you can use continuously. Because if you are using something that should not be a continuous pill, you set yourself up for an unplanned pregnancy.
Correct.
So that's really important to, again, talk about what your strategies are with your provider to make sure you're getting the right instructions.
Exactly. And I think it's sometimes not discussed enough.
Exactly.
Because, we assume, all birth control pills are equal, but they're not. They have different amounts of the hormones that are in them, and they maybe do different functions.
Exactly.
And
Right.
so that's why, as Dr. White Hathaway says so eloquently, please keep the lines of communication open.
Okay. The one other thing I was going to say that's new on the market that, in addition to the Lupron, it works similar to Lupron in that, again, it's kind of tricking your body into thinking that you're menopausal and you don't need to produce estrogen anymore, is a pill now that's out called Oralissa. It's been out on the market for about a year. And
You probably have seen the commercials on it, too.
that's why endometriosis,
Yeah.
this is perfect because this is endometriosis month, as you had referred to. And you're going to see a lot more commercials kind of trying to bring home the fact that painful periods is a problem and you shouldn't have to live with it, or at least talk to somebody about it and see if it's normal or not normal. But this new medication is called Oralissa, and it works like Lupron, but it's in a pill form. And there have two different types of dosing, depending upon how severe your symptoms are, might depend upon what kind of dosing you need.
Yeah. Now, will someone always have endometriosis? And that may be a little trick question, because in theory, like you said, if we do definitive treatment, no, you won't. But if we don't do definitive treatment, will they have it?
They may have the tissue being implanted in places outside the uterus, which is the definition of endometriosis. Will they be symptomatic with their endometriosis is the question. And I think is what your question is. Well, and I don't think that you will always have to be symptomatic with endometriosis.
Correct. You don't have to suffer at all.
Exactly.
Now, we talked about and we touched on fertility, because that's a big thing for women that are in the age groups that endometriosis affects. You're the, 20, 30, 40-year-olds. So what would you say to a patient who is having issues?
Well, I first would say that in infertility, there are certainly several causes of infertility. So you still have to do the entire workup for infertility, and try to make sure that you know exactly what the whole package is. And male infertility is 40% of the problem. So oftentimes, I think we forget that. We always think that it's
always the
always the woman. So you have to do it as a couple. I strongly approach infertility as a couple's journey. And if you do, kind of go through the steps and find that everything is pretty unremarkable in your workup, and you're still trying to find out what is the source, a lot of people will go ahead and do laparoscopies just to kind of take a look at the pelvis and see if there's anything going on. And then once, if you do have endometriosis that's diagnosed, depending on if it's caused scarring and it's affected your tubes and your tubes are no longer working, then dealing with the fallopian tubes and kind of maybe removing them and doing things like IVF, those are certainly appropriate ways to manage infertility that might be associated with endometriosis and problems from endometriosis.
Absolutely. So this show has been packed with a wealth of knowledge that I know the viewers are going to be thankful for, that they've heard. You can't hear it too much. Endometriosis is one of those conditions that is not really talked about
Right.
in the manner that it should be talked about. So, you know, I just want to leave with some parting words here. It's not preventable. Like, we can't say, oh yeah, you know, I can prevent you from getting it, but you can implement things into your lifestyle, as we touched on, that may help you in the long run. Exercising is one of them. Avoiding large amounts of caffeine. We know that caffeine can actually increase the estrogen levels. So decreasing your caffeine levels, decreasing the amount of alcohol that you use as well. And just once again, talking with your physician and being open with your physician about what's really going on, because we can't help you if we don't know.
Exactly.
So I thank you so much for...
Well, thank you for having me.
Absolutely,
It's my pleasure.
I thank you, and I look forward to many more talks with you.
Absolutely.
And many other OBGYN issues. So until we see each other next time, have a blessed week.